Hello and welcome everyone, and thank you for being here. My name is Philip Bardos. I'm a recent master's graduate from Virginia Commonwealth University. I'm joined here by my advisor, Dr. Laura Padilla. And our work that we present here today is a clinical evaluation utilizing AlignRT for the setup of stereotactic body radiation therapy patients. And so first, our disclosures are that we have no personal or professional conflicts of interest with this work, and we did not receive any funding from any organizations or companies. So in this talk of how we performed our data collection, introduction of our system and how it's implemented in our clinic, then delving into a little bit of how we performed our data collection, is followed up with our analysis and results of that data, some discussion about some of the cases that are not statistically significant for our data, and then finally finishing with our conclusions and any outlets for possible future work. And so this here is our system. We currently have the AlignRT system in just our TrueBeam vault. So it is present in one of our 3 vaults. We do, however, treat SBRT patients on 2 of those vaults. So that is the TrueBeam vault, where the AlignRT is, and then our Trilogy vault. The version that we are currently using is 5.0.1747. We do not have the HD cameras yet, but we do have the standard cameras. And the system was first installed in 2013 and remained dormant for a few years until Dr. Padilla came in, and it got its first clinical use introduced in 2016. And so all of our data for our AlignRT setup patients comes from 2016 onward, whereas where most of our patients that were set up without AlignRT is from 2015 onward. And so AlignRT has often been used to set up left-sided DIBH breast patients, but we currently at our institution do all those patients on our Trilogy. So as this is only on our TrueBeam, we had to find another alternative as to what we could use its implementation for. And so we do treat a lot of SBRT cases on our TrueBeam, and that was what we decided to go with. And some reasons that we decided to go with that is the longer treatment time slots that are allocated for those treatments allow for more refinement of our process of this implementation. Similarly, as internal imaging is always performed, we have another metric in which we compare our AlignRT efficiency and setup. We do have physicists present at every fraction of SBRT, as well as the therapist there to treat, and then we do have a radiation oncologist for approval of the cone beam CT, and sometimes they're nice enough to stay around for a little bit. But so that allows us all in the treatment team to become familiar with it each and every fraction. And so this is our original workflow that we had prior to the implementation of AlignRT. So first we would set up our patients to tattoos and lasers. Then we would perform a shift to the treatment isocenter if necessary, followed by our 2D orthogonal KV imaging, then getting into our volumetric cone beam CTs. And we have institutional policy in which we do perform a rescan of our cone beam CT if we have greater than 1.5 centimeters overall in all directions, or greater than 8 millimeters in one direction. And so if this criteria is not met, a rescan is automatically performed. And similarly, the physician can not approve of the image, and we would acquire another cone beam CT. And then upon physician approval, we do begin our treatment. And so this went on for several years, and then in 2016, when we actually started using our AlignRT clinically, we thought how to best not modify this procedure so that we're not breaking away from the current workflow, but how to enhance that workflow. And so we thought that between the shift to treatment isocenter as well as the 2D orthogonal KV imaging, we could perform refinements in the position with AlignRT. And so we are looking at, in some current ongoing studies and then some future studies, about refining these first few steps to essentially be surface imaging and then moving into our 2D KV imaging, as well as our volumetric CBCT. And so the study itself, it was a retrospective study. It was not prospective, although we would have liked it to have been. We're looking at trying to assess whether the implementation of AlignRT and the setup of SBRT patients had an impact on the average number of cone beam CTs that were required per fraction. And so just looking at, based on where some of our locations of our tumors were, the sites included lesions in the abdomen, lesions in the lung, and then we have kind of an other category for our lesion locations, and those are just lesions that are in the bone, excluding any ribs that may have occurred. So these are typically vertebral lesions. And then we did also assess whether respiratory motion management patients had an effect versus patients who did not have respiratory motion management. And our respiratory motion management is ABC. And so the actual breakdown of the patients for the retrospective study was 81 patients in total over 386 fractions. And each of our SBRT patients are typically treated in 3 to 5 fractions, anywhere from 5 to 12 gray. And most of the cases were lung, liver, and pancreas, but we thought how we could kind of split this up and do a subsite analysis based on the location of the tumor. And so we do have an abdomen subgroup, a chest subgroup, a lung subgroup, and an other subgroup. And so the abdomen subgroup contained lesions that may be present in the liver, pancreas, and gallbladder. Chest included all lung lesions as well as the ribs. We do have a lung subgroup by itself, as there were so many lung patients. And then we do have, as I explained, the bone subgroup excluding the ribs for the other. And so this is the actual breakdown of patients that were treated and set up with AlignRT and those that were without. If you look at just the total number of patients itself, there was 29 who were set up and treated with AlignRT, and treated, and then 52 who were not set up with AlignRT. And we do see that looking at abdomen and ABC, there is a relatively even distribution between the two groups, where there is discrepancies between the chest, lung, other, and no ABC categories. And this is just indicative of the retrospective study and the nature of the study. And one other important thing to note is that a patient could be present in, let's say, ABC and abdomen and all patients. Similarly, they would be present in lung, chest, so you can have patients who are in multiple groups. And now looking at the actual fraction analysis, we see the same trend in which abdomen is close compared to that of chest, lung, and other. ABC is close compared to that of no ABC. And so looking at all the fractions, we do see that the dispersion of data is 114 were set up with AlignRT, and 272 fractions were set up without AlignRT. Again, just being a retrospective study. And so for the actual creation of our reference surfaces, all of our patients were simulated on our CT with a 3 millimeter slice thickness, and that DICOM data was sent over to the AlignRT system. If they were an ABC patient, they did have a breath hold scan acquired, and that was what was sent over. And similarly, if they were a lung-free breathing patient, we used a 30% phase exhale scan from their 4D CT and sent that over. For the actual alignment of the patient, on their first fraction, we simply set them up to the DICOM. And during that fraction, if it's an ABC patient and the first breath hold, they would acquire reference capture, and that reference capture would be used to monitor for that fraction as well as set up for the next fraction. And if there was issues with the setup of that reference capture in the next fraction, we would always resort back to our DICOM data as our standard. And we did not use any gated reference captures. And so here is 2 examples of some of the ROIs that we had on our system. And this is just to show the limited extent of external anatomy available. So as you can see in this lower case here, it doesn't have the full range of the planning CT utilized for the ROI creation, as we see in this top case, where this bottom case is limited to just this extent, whereas this top case we could extend a little further as well. And each of these ROIs are DICOM dependent, which are made from DICOM, which is patient dependent and treatment site dependent. And so these are nice looking surfaces. They're very smooth, but we did have to adjust some of our reference captures. And this would be due to the fact if there was an occlusion on the patient surface, whether it be a tube, some patients who got cold would request sheets. And so as these are not reproducible treatment to treatment, we would edit the ROI to exclude them from our actual analysis. And so, as I mentioned before, the overarching question is we're trying to see if AlignRT implementation reduces the average number of cone beam CTs per fraction. And so when we assess this question, we obtain these results here for our patients. And as we can see for all patients, comparing the category of those set up with AlignRT versus those set up without AlignRT, we do see that there is a reduction for all groups. The largest reduction being in the abdomen case, in which we have a 0.42 reduction in the number of cone beam CTs when setting up per fraction when setting up with AlignRT versus those that were set up with not with AlignRT. And then just similarly looking at all patients, we have 1.1 for those set up with AlignRT and 1.3 set up without AlignRT. And so this all looked promising, but we performed our statistical analysis. With our statistical analysis, our data is not normally distributed, so it would start at a minimum of 1 cone beam CT and be skewed. And so we had to utilize this non-parametric test, which is the Mann-Whitney U test. And this is simply just for tests that don't follow the normal distribution with 2 independent groups. We do have an alpha set for our statistical analysis of 0.05, and we did utilize MATLAB for all of the statistical analysis. And so the results of our statistical analysis were that for the abdomen, the ABC, the no ABC, and all patients, there is statistical significance. And so we see here that chest does not have statistical significance, as well as lung or other category. And so we did some brainstorming as to thinking why this might have occurred for these categories, why chest might have occurred when all patients, or chest was not significant, but all patients was. And so we came to the conclusion that as we are acquiring our reference captures at different phases in the breathing cycle, as we're not using gated reference captures, that could have led to the lack of statistical significance for our chest and lung. And looking at the other category, our sample size was small. So we had only 7 fractions of patients who were set up with AlignRT, and we had 43 who were set up without AlignRT. So that was small compared to all our other subsets. Similarly, all these lesions in the other category were vertebral lesions, and simply just using orthogonal KVs before CT aligning to bone might be more significant for that case. And then here's, again, the results for all patients category, in which we see a decrease in the average number of cone beam CTs per fraction from roughly 1.3 to 1.1. And so this may not appear that significant, but we did some further analysis assessing essentially the range of the number of cone beam CTs per patient. And we see that for highlighting the statistically significant cases, we see that for difficult setups in which 2 or more cone beam CTs are required, the use of AlignRT helps to mitigate this. And you can see for all these statistically significant cases highlighted in green that the values for 2 cone beam CTs as well as greater than 2 cone beam CTs is less than that of those set up without AlignRT. And so, as I mentioned earlier, all those patients who were not AlignRT for the most part were treated on the Trilogy. There was a few on the TrueBeam. So we thought that maybe this could be due to the fact that there's differences in the image quality between our Trilogy and our TrueBeam. So we did a separate analysis in which we assessed whether the patients treated on the TrueBeam, whether it was still statistically significant. And so we used patients that were set up with AlignRT on TrueBeam for, let's say, abdomen, those that were set up without AlignRT for abdomen on the TrueBeam, and performed an analysis between those. And it still proved that our data was significant. And so some things to keep in mind, this was a retrospective study. We did have different sample sizes because of this. So for our AlignRT population, we had 114 fractions, and for our non-AlignRT setup, we had 272 fractions. We also did have different patients treated on different machines with different tumor locations. Some additional things to keep in mind. This was our first implementation of AlignRT into our clinic. So we did have inconsistencies in reference surfaces due to fraction to fraction, patients wanting sheets or maybe the location of the tube. We did have inconsistencies in the ROI definition. There was a learning curve for everyone involved. This was the first implementation. And down here we do have therapists rotating every 3 months to different machines. So certain therapists would pick it up faster than others, and even if they picked it up fast, they were rotating to another machine in 3 months, so we wouldn't see them for a while. And we'd have to teach someone else how to use it. And so then in conclusion, we found that AlignRT is helpful in reducing the number of cone beam CTs for those difficult setup cases. But we do have to keep in mind that this was a retrospective study with uncontrolled confounding variables, and this was our first implementation. And here, the AlignRT improves safety in both setup and monitoring. For monitoring, you have constant monitoring of the patient throughout the treatment. And with this, the setup itself, outside of the tattoos and lasers, you have a larger extent of anatomy with which, if the patient moves, you would be able to see easier. And our future work that we would like to design is some prospective studies. So this first one is comparing AlignRT and cone beam CT with that of orthogonal KV and cone beam CT. And that is ongoing right now, and we'd like to also delve into substituting laser setup with AlignRT. This may seem backwards to some of you that we are doing this one first instead of this one, but the reason we're doing the comparison with orthogonal KV is we felt that was the least deviation from the current culture in the clinic and the current workflow, and that once this was hammered out and therapists felt comfortable with it, we could then dove into this. In addition, we didn't have any treatment setup times tracked, so we'd like to be able to track those actual treatment times to see the efficiency and the time metric. And then outside of SBRT, we do have conventional fractionation cases on our TrueBeam, and we'd like to compare that as well for conventional treatments.
So there is something that I want to comment on. So even though the difference is statistically significant, right, between aligning the patient with AlignRT or not using AlignRT, the reduction seems really small, right? So you're going from an average of 1.1 or an average of 1.3 cone beam CTs per fraction to an average of 1.1 cone beam CTs per fraction. So it really doesn't seem like it would be earth-shattering. Well, what that really indicates once you look into it is most of the patients are only going to take one cone beam CT to set up. Most of the patients set up fairly nicely, so you only need to take one set of images and you're fine. AlignRT helps when that's actually not the case. When the patient is a difficult setup, we have found that it helps you get that position right without having to take so many cone beam CTs. So in our clinic, by institutional policy, we have to re-cone beam CT the patient if our shift is greater than 8 millimeters in one direction or 1.5 centimeters overall, right? So if you are shifting when you match by more than that, you have to re-cone beam CT. Every time you re-cone beam CT, it takes a really long time, especially if the patient is an ABC patient. Plus you have to get the physician to actually come and approve the images, so that's really our workflow bottleneck. So even though it might not seem a huge difference to go from 1.3 to 1.1 average number of cone beam CTs per fraction, it actually has made a huge impact in our clinic as far as workflow efficiency goes. Aside from the fact that you still have, regardless of whether it's statistically significant, the reduction or not, you still have the pluses of being able to monitor the patient while you're treating and having a larger extent of anatomy to set up to begin with. So there's no confusion with, are we at the right vertebral level or not? You know where you are because you can see more of the patient.
So one of the things you said that you guys are looking at doing in the future is kind of eliminating those first 3 steps in your current workflow and kind of moving away. We heard from some people this morning of not having tattoos or not having those marks. So what do you think will help, I guess, get you guys there? Was your hesitation, or do you guys have any hesitations or kind of thoughts on that?
Institutional culture is a huge issue. It's really hard to get therapists and physicists also sometimes to wrap their head around the fact that they will no longer have that one little dot on the patient to line up to. Also, another issue that has been brought up is, well, what if the system goes down? The system doesn't go down that often. The system goes down less often than the treatment machine does. So it should be, that part should be okay. So it really is a matter of getting people used to using AlignRT. Yeah. And just having them be comfortable with what it is that they're doing and the results that they're getting. And I feel like that will just be a natural progression towards it. But it's been an interesting experience.
Because I know you said that you guys started in 2013, or you had it, but you didn't really put it into practice until 2016.
Yeah.
So I don't know if you had any experiences to share in your implementation or advice to give.
So,
be patient.
Yeah. So I started working with AlignRT during my residency. You actually were the trainer at Chicago, I remember. So I did a lot of work throughout the 3 years that I was at Chicago. And then I got hired at VCU, and one of the reasons why they hired me is because they had this system that was just sitting in the vault and nobody was using. So they were like, all right, you're gonna implement it. So just being new and trying to push a new system on people, and just, they're looking at me like, who are you? So I think one of the things that's really helpful is, even though it might seem like you're just making your treatment setup time longer, just try to introduce it little by little and let people see how actually setting up to the surface will be more efficient and will be more reliable rather than just doing the 3-point marks. So just be patient and let people just see the results for for themselves, because that helps a lot in implementing the system, any system really. but be patient and get the chief therapist to buy in. That's the first person that you want on your side. From there, everything is easier. But
You guys have an institutional policy of like 8 millimeters in one direction, you have to read cone beam.
Mm-hmm.
Do you feel like, I mean, I know your study was just, like, see that reduction in cone beams, but do you feel like your policies may change because now having this technology and being able to use it, that'll go down or increase, or you'll have any other changes just because you have it in place now?
I think for now,
Yeah.
just getting away from the orthogonal KVs is going to be a huge step. Yeah, reducing the number, the actual threshold might be a little bit of a bigger issue to bring up, but we really have seen the fact that we don't need to take as many cone beam CTs now that we're setting up to the surface. And one of the questions that people have asked in previous sessions has been, well, why would you see such a big difference between the abdomen patients and the lung patients? Like, why would it be so much more statistically significant? And aside from breathing motion and all that stuff, there's also the fact that if you have the surface and the bony anatomy both as an option when you're lining up the patient, the first fraction, you're gonna see if the tumor correlates better with the bony alignment or with the surface alignment, right? So in a subsequent fraction, if you know that it correlated better to the surface, you kind of have that in the back of your head and you're like, all right, well, even though if I align to bone, I want to go 5 millimeters to the right, I know that it correlates better with the surface, so I'm going to trust that instead. So just going with that and knowing what aligns best for that one particular patient helps a lot in reducing the number of cone beam CTs. So.
It's like that patient, you like slowly move the marks because you know if on this side of the mark that
Exactly.
day, your image is going to be on. It's kind of like those tendencies you learn per patient.
And you see that a lot more in abdomen patients than you do in lung, because it's not like the lung tumor is going to start, moving to. But if it's something that's in the liver or in the pancreas, you do see that discrepancy almost between the bony alignment and the actual tumor location. They are quiet.
How do you guys use your trilogy for your
Breast.
patients?
I don't think there's any particular reason for that other than that's the way it's always been. So they're just used to treating the breast patients in the trilogy, and they started treating more and more SBRT patients in the TrueBeam. So all of the patients that were treated in the trilogy for SBRT before have now moved to the TrueBeam. So it just worked out to where the schedule is now busy enough in the TrueBeam and empty enough in the trilogy that if we leave the breast patients in the trilogy and just treat SBRT in the TrueBeam, everybody is kind of happy and the schedule just kind of works out for everyone. There's not really any particular reason other than that's the way it's always been.
The IBH?
Yes, and we do the IBH with ABC, which is really why I was trying to move the breast patients to the TrueBeam, because it's a little traumatizing for patients when you first start simming them with the ABC system, because they most of the time just found out they have cancer. They are not in a good place mentally. You have them on the table with like 3 or 4 people around them. They have a breathing tube in their mouth. You're telling them that the breathing tube is going to stop them from breathing for like 20 to 30 seconds. And they're looking at you like you're putting them through a torture device. So it would be really nice if we could just move those DIVH patients towards the TrueBeam and just do it with AlignRT instead of ABC. Even more so because we have seen instances where the ABC patients will just breathe around the tube. So the consistency in the breath hold volume that you think you're achieving is actually not all that good. So patient compliance is huge versus if you are treating those DIVH patients with surface imaging, there's no way to cheat that. Like they either make it to the threshold or they don't. So we're trying, which is, it's a lot of things to, coordinate.
You were saying that you've noticed more of a difference and decreased the number of cone beam CTs, particularly those patients who are poor setup or maybe not a poor setup, but difficult setup. Have you tried at all to triage that ahead of time and be selective, like for those patients with a large BMI or those patients with poor performance status, the patients who don't have the muscle?
Yeah, so we've looked into that. But every single time we think we know how to triage the patients, it turns out we don't. We have had patients with large BMI that set up beautifully. They are extremely reproducible and there are no issues. And we have had more, I guess, thin patients that were extremely difficult to set up for whatever reason. So it's not as easy as one would think to triage them ahead of time. And then there are some patients that their tumor location will always correlate to their bony anatomy, and then there are some patients that one fraction it correlates better with bone, the next fraction it correlates better with surface, and so you kind of are left with just this uncertainty that you don't really know which way to go. So we try, but it's hard to come up with any good, robust way of doing so. Anything else?
Thank you guys.
Thank you.